Hey, stroke. So, based on my beard and my haircut, you can probably tell I'm taping these during the coronavirus situation. Stroke. Lots to know about stroke. Pharmacology is not as critical to know as it is in some other areas, but there's definitely some pharmacology that's associated with stroke. I'm going to cover the general concepts of stroke and talk about the pharmacology integrated into that concepts. So Mr. Orville Boren is a 68-year-old guy. He's African American, and he just had a right CVA. It was a thrombotic CVA. It was about a week ago. So what would we expect to be going on with him? Well, looking at his background, he was a history instructor at the local community college. He was a wood carver. He was a gardener. He was very active in his church. And so we worry that both for cognitive and physical reasons, he's going to have a hard time getting back to these things. But we'll have to see what his basic function is before we can think about that. He's on a hypertensive medication and has been for the past 2 years. He says he does often forget. We also need to pay attention to that. He's always paid for all the bills. His wife definitely wants to care for him. And with someone with his history, he can be anywhere from 99% normal to completely hemiparetic on that left side. We said he had a right stroke, right? So we would expect a left hemiplegia or paresis. Paresis is weakness. Plegia is complete paralysis. Usually that hemiplegia is more likely to be flaccid, but it could also be spastic. His vision might be affected because he could get field cuts. We'll talk about that in a minute. It would be unusual for him to be aphasic. Most people that are aphasic are left strokes with a right hemiparesis. Even people that are left-handed are more likely to be like that, although they are about 20 to 30% more likely to have their speech center on the right side. So if he's left-handed, he would be a bit more likely to be aphasic, but he would be most likely to not be aphasic. People that have a right CVA often are very depressed as well. Way out of proportion to what you would expect related to the illness. And they also may have a left-sided neglect, which is kind of a fascinating phenomenon in which if the patient is at their midline and something happens to the left side, they don't even know it exists. They don't even know that left side of their body exists. If you pull it across to the right side and they see it, they now perceive it. It's kind of a fascinating phenomenon, and those of you that end up doing neurology, I think you'll find it very interesting working with those people. Most strokes do come from a clot, but not all. And the clots can develop in place. If the clots develop right there and get thicker and thicker and thicker, and then eventually kind of block off, we call that a thrombotic stroke. If the clot comes from somewhere else, or even a bubble of air or a little bit of fat, we call that an embolus. So anything that's traveling through the bloodstream is an embolus. Plural of embolus is emboli. More likely to be associated with younger people, more likely to be associated with atrial fibrillation. And there's even a third possibility with stroke, and that's that they have bleeding. And someone that has a hemorrhagic CVA is much more likely to die. These are the people that often get that thunderclap headache, in which it's the worst headache of their life. Those people need to be taken very seriously. They will usually have a really severe headache, and they need to be scanned right off. And interestingly, in general, you want to do a spinal tap on those people too, because if they have bleeding, it usually will get into the CSF, and you may see that before you see any abnormalities on CT or MRI. These people may vomit because of the increased intracranial pressure, and the flaccid paralysis is very common in that case. Also could have a spastic paralysis, but they usually have a very flaccid paralysis. In people with thrombotic strokes, they'll often have had some symptoms before. They'll often have had TIAs. Now, TIAs are a factor which increases the risk of stroke, but not create a situation in which stroke is destiny. So if somebody's had a TIA, let's say a person is 1% likely to have a stroke, TIA makes them 4 or 5% likely. That's still 95% of people that won't have a stroke, but it does increase their risk substantially. So for TIAs, the symptoms may be present for minutes up to 24 hours. We used to diagnose TIAs a lot more than we do now, and that's because we do MRIs a few days later, and we'll often see that there may have been some micro insults. So oftentimes people are diagnosed as having had a small stroke instead of a TIA at that point. TIAs can have symptoms of numbness, they can have symptoms of weakness, they'll have difficulties with speech, word finding, those kinds of things, or they may have a transient blurred vision. Lots of different things that can happen. So Orville had some dizziness, a little bit of blurred vision. He had attributed it to being tired, thought maybe he was starting to get migraines, although migraine onset in this age would be very unusual. They only lasted a few minutes. He thought, you know, maybe he was in the sun too much. So right now, Orville can't move his left arm or leg. And so he also can't speak. So chances are he was left-handed. And so he is one of those people that has a aphasia associated with a stroke, even though it's unusual with a right-handed stroke. He also seems to have some field cuts. So when you ask him, can he see certain things, he has a hard time seeing them. His CAT scan with a thrombotic stroke in the first 24 to 48 hours, even up to a week or so after, is usually negative. As time goes on, if there is damage to the brain, it will start to show up on the CT scan. It'll often show up on the MRI much sooner. So, you know, can show up as soon as a couple of days after. So if he was truly a week out, chances are he probably would start to show some changes on his CT scan. But if he's taken to the emergency room immediately, he would not have. He would have a negative CAT scan. Hemorrhagic stroke does not have a negative CAT scan right off. They usually do have changes. And again, you need to do a spinal tap on those people if they have a presentation that makes you think of a hemorrhagic stroke. So if he had had symptoms and gone to the emergency room, we very well would have done that CAT scan. If the time from the first symptom to the time that we could administer the medication was less than 3 hours and he had pretty substantial symptoms like he does, he would definitely be a candidate for alteplase or a clot buster. We're also seeing that there probably is benefit up to 4.5 hours after first onset. The challenge, of course, is that it's really hard to know when somebody's first onset of symptoms were. Oh, I had a little bit of a headache yesterday. Oh, I did feel a little bit of numbness in my leg earlier today. And so the people with clear-cut symptoms are relatively limited. And it's really 5% or so of people that often get these clot-busting drugs at this point. The surgical procedures can be done up to a day or two later to remove the clot, and that does seem to decrease the amount of the penumbra, the amount of tissue that dies. But as far as clot busters right now, you have to do them in the first 3 hours, and then alternatively in the next 3 to 4 hours. 4.5 hours. Unfortunately, there is an increased risk of bleeding associated with these. So if you look 90 days out, about 15 or 20% of these patients have substantially less disability. The problem is that if you give them clot busters in the first day or two, 1 or 2 will probably die that might not have. So it's not an easy decision for clinicians. It's not an easy decision for families. It is something that we do seem to be making some progress with, but it is still, I think, a very difficult situation. So he might have a homonymous hemianopia or hemianopsia. All right, so what happens here is you have a situation in which the vision from the right eye, part of it goes through and then crosses through the optic chiasm and then goes to the left part of the brain. Think of this as the brain back here. The other thing, though, is that part of it doesn't cross over. Part of it just goes to the right side of the brain. So that if you have damage to the right side of the brain, a clot back here, you're going to damage this track, which goes over here, and this track. Note that these are different eyes, one eye, two eyes. Actually, I've done this backwards, but I think the concept is still going to work fine. You got a situation here where that is gone. So you lose the right-hand side of each eye. So they can't look over to the right-hand side and know what's going on. And again, he's probably lost the right-hand side of his vision since he had a right stroke. So what do we do for Orville short term? He's got a clot. So we want to allow the body to get rid of that clot. Alteplase may accelerate that. And we want to stop new clots from developing. So very frequently, after we've used thrombolytics, if we're going to, they'll often be put on a heparin drip or give some kind of antiplatelet medication, such as aspirin or Plavix. There's some newer ones that are also being used, but we'll go with the basics at this point. And in the long run, we also want to decrease his risk of clotting. He's diabetic. He's not diabetic, so we don't need to worry about that. He does have hypertension, so we'll look at his medication regime and optimize that. If his cholesterol is off, we'll try to optimize that. And there's also some other things that might decrease the risk of clotting. And again, these are these blood thinning type medications. So aspirin and Plavix, depending on the type of stroke, we'll usually use a full strength aspirin. Sometimes we'll add a second platelet inhibitor to that in the form of Plavix. Sometimes we go with an actual anticoagulant, and Coumadin is very commonly used, although the NOACs, or also known as the DOACs, which are the direct oral anticoagulants. NOAC stands for novel oral anticoagulants. Those are also being used, and there seems to be some evidence that the anticoagulants may even decrease stroke more than the platelet blockers, but the problem is that the platelet inhibitors have a much lower risk of bleeding than the actual anticoagulants. So time will tell. So what about his aphasia? Well, it could be expressive, meaning that he has a hard time organizing and expressing his thoughts. It could be receptive, meaning he has a hard time understanding. If he has an extensive clot, it could be both. It could be that he can't understand or express. That's obviously very distressing to everybody involved. And so remembering that the expressive portion and the receptive portion are different parts of the brain. He may also have problems with mathematics. He may have lots of different cognitive changes. We may actually need to do neuropsychological testing afterwards to figure all of that out. So just to reiterate, aphasia is a disorder of language. It's producing the language in the brain. Dysarthria is a disorder of speech. So if someone has a hard time talking because of their motor function in their lips, that's dysarthria. That's not dysphagia or dysphagia or aphasia. So seizures is definitely something we worry about after stroke. It's not very common, but keep an eye on it. We'll be talking about seizures in a little bit. They're rare in stroke, but they are common in other types of closed head injuries. And really, stroke is kind of the prototype of a number of different closed head injuries, although all closed head injuries are often very different. So we'll talk more about seizures in another talk. So again, you could have generalized seizures all over the body, acute tonic-clonic, where they have tone and then that tone relaxes and then they have alternating movements. Partial seizures are a little harder to figure out. Deja vu is the sensation that you've been somewhere before. Usually those are temporal lobe seizures. Absent seizures are more in children. And again, we'll kind of talk about that in a little bit. Orville didn't have seizures. He actually got substantially better. He got a lot of return. He did still need a walker, but he was able to feed himself. Most people with stroke, 70 to 80%, get pretty good return of their leg. Only about 15 or 20% get pretty good return with their arm. And they'll often have to walk with a walker and use a sling. Very frequently, the walker that they use is something called a hemi walker, and it's only used on one side. I'll let you look up on the internet what a picture of a hemi walker looks like. His vision actually returned once the swelling went down in his brain. His speech is still a problem, but he's going to speech therapy and is improving, and he's having ongoing rehab and care. And so here's some drugs of the week. I don't have a NOAC or DOAC on here, but let's talk about apixaban as an example of that.